Successfully differentiating birth-related head injuries requires understanding their anatomical locations and temporal presentations. Caput succedaneum represents scalp edema that crosses suture lines, appears immediately at birth, and resolves within 24 to 48 hours through natural resorption. This benign swelling requires only reassurance and parental education about its self-limiting nature. Cephalohematoma presents distinctly as blood collection between the skull and periosteum that respects suture boundaries, never crossing these anatomical landmarks. Unlike caput, cephalohematomas develop gradually over the first 24 hours as bleeding accumulates. Resolution takes 2 to 4 weeks, during which bilirubin monitoring becomes essential due to red blood cell breakdown. The critical management principle is never aspirating these collections, as this risks introducing infection into a sterile hematoma. Subgaleal hemorrhage represents a true pediatric emergency with 22% mortality. This collection occurs beneath the galea aponeurosis, crossing suture lines and extending to the neck and ears, creating a fluctuant mass that can accommodate massive blood loss. Immediate recognition triggers aggressive volume resuscitation with crystalloids or blood products, frequent hematocrit monitoring every 4 to 6 hours, and preparation for potential surgical intervention. The extensive potential space allows for life-threatening hemorrhage that can rapidly progress to hypovolemic shock, making early identification and prompt treatment absolutely critical for survival. Recognizing perinatal asphyxia requires systematic evaluation of multiple clinical indicators that reflect the severity of hypoxic ischemic injury. The extended APGAR scoring system provides more reliable prognostic information than the traditional 5-minute score, with very low scores at 20 minutes strongly associated with neurologic morbidity. Laboratory testing confirms significant fetal acidemia through a pH value of less than or equal to 7.0 or a base deficit of 12 to 15 milliequivalents per liter, measured from umbilical cord blood or arterial blood obtained within the first postnatal hour. The requirement for positive pressure ventilation lasting more than 10 minutes indicates severe cardiorespiratory compromise and signals the need for urgent intervention. Multisystem organ dysfunction reflects the so-called diving reflex response, in which blood flow is preferentially directed to the brain at the expense of the heart, kidneys, and liver. Nearly all affected infants show evidence of dysfunction in at least one organ system beyond the central nervous system, making this a key diagnostic pattern. Immediate management prioritizes establishing effective ventilation as the foundation of resuscitation. Preventing secondary injury requires close attention to normal glucose concentration, body temperature, and blood pressure. At the same time, clinicians must evaluate whether criteria for hypoxic ischemic encephalopathy are met in order to initiate therapeutic hypothermia. Because the neuroprotective effect is time-dependent, treatment must begin within 6 hours of birth to achieve the best outcomes. The Sarnat staging system provides essential prognostic information that closely correlates with long-term outcomes. Infants in stage 1 appear hyper-alert with the characteristic stunned look or blank stare, showing uninhibited moro and stretch reflexes with normal electroencephalogram patterns. These infants have virtually no risk of later major neurodevelopmental disability. Stage 2 represents moderate encephalopathy, with obtunded behavior, generalized hypotonia, weak sucking, constricted pupils, and a diminished moro reflex. Clinical seizures are common, and electroencephalogram monitoring often reveals periodic discharges, sometimes preceded by continuous delta activity. Approximately 75% of these infants survive without major neurologic impairment. Stage 3 is characterized by stupor or coma, flaccid muscle tone, absent reflexes including sucking and moro, and poorly reactive pupils. Intermittent decerebrate posturing may occur. Mortality in this stage ranges from 50 to 100%, and 65 to 75% of survivors experience severe disability. Eligibility for therapeutic hypothermia requires a gestational age of 35 weeks or greater, evidence of perinatal asphyxia with a pH value of less than or equal to 7.0 or a base deficit of 16 or greater, or a 10-minute APGAR score of less than or equal to 5, together with moderate to severe encephalopathy. the 6-hour treatment window reflects the timing of secondary energy failure, when neuroprotective interventions remain most effective. Clinical seizures frequently emerge between 6 and 12 hours after birth, occurring in 50 to 60% of infants with moderate to severe hypoxic ischemic encephalopathy. Therapeutic hypothermia represents the only proven neuroprotective therapy for HII, reducing cellular metabolism by 5 to 8% per degree Celsius while attenuating inflammatory responses and stabilizing the blood-brain barrier. The protocol requires precise temperature control at 33.5 degrees Celsius plus or minus 0.5 degrees Celsius for exactly 72 hours, followed by controlled rewarming at 0.5 degrees Celsius per hour over 6 or more hours. Temperature management demands vigilant monitoring, as overcooling below 33 degrees Celsius risks cardiac arrhythmias and other detrimental effects. Sinus bradycardia occurs as an expected physiologic response due to slowed conduction through the sinoatrial node. Thrombocytopenia affects approximately 28% more patients compared to normothermic controls, while subcutaneous fat necrosis occurs in 2.8% of cases, particularly on the back and shoulders. Hypothermia significantly alters drug metabolism through effects on CYP450 enzymes and glucuronidation pathways. Morphine clearance decreases by 25%, phenytoin by 67%, and phenobarbital by 99%, necessitating careful dose adjustments during cooling. These pharmacokinetic changes require particular attention to prevent drug accumulation and toxicity. The intervention reduces combined death and severe disability from approximately 65% to 45%, with a number needed to treat of 7. Outcomes vary by severity, with neuroprotection being most pronounced in moderate encephalopathy compared to severe cases, emphasizing the importance of early recognition and timely intervention. Birth-related intracranial hemorrhages often occur without obvious scalp or head trauma, making recognition dependent on understanding their distinct pathophysiology and presentation patterns. Subdural hemorrhages result from tearing of bridging veins that traverse the dura mater, with blood collecting below the dura and above the subarachnoid villi. Risk factors include vacuum or forceps-assisted delivery and coagulopathy. Most subdural hemorrhages remain clinically silent and resolve without intervention. Symptomatic cases typically present 24 to 48 hours after birth with nonspecific signs including apnea, respiratory distress, altered neurologic state, or seizures. Large hemorrhages or ongoing bleeding may require neurosurgical drainage, but most cases need only supportive management with serial monitoring. Subarachnoid hemorrhages occur when subarachnoid villi veins tear, creating blood collections that irritate meninges and adjacent cortex. The classic presentation involves seizures on day 2 of life due to this irritation. Large subarachnoid hemorrhages can impair cerebrospinal fluid resorption, leading to secondary hydrocephalus requiring ongoing surveillance. MRI provides superior imaging compared to CT when available, offering better sensitivity for detecting both hemorrhage types and associated parenchymal injury without radiation exposure. Cranial ultrasound lacks adequate sensitivity for extraaxial hemorrhage detection. The overall prognosis remains favorable, with an estimated 80% of infants achieving good outcomes when managed appropriately. The ILAE classification recognizes that 50 to 80% of neonatal seizures are electrographic only, lacking visible clinical signs, yet requiring EEG detection and treatment. Motor seizures include 4 primary types. Clonic seizures demonstrate rhythmic jerking with fast/slow phases, distinguished from jitteriness by persistence despite restraint. Tonic seizures involve sustained flexion or extension lasting seconds to minutes, affecting limbs, eyes, or neck. Myoclonic seizures present as lightning-fast jerks under 100 milliseconds, requiring EEG correlation to distinguish epileptic from non-epileptic events. Non-motor seizures encompass autonomic and behavioral arrest patterns. Autonomic seizures manifest as paroxysmal cardiovascular, respiratory, or pupillary changes, with EEG correlates, though isolated apnea rarely represents true seizure activity, with less than 5% showing ictal patterns. behavioral arrest involves pauses in normal activities with simultaneous EEG changes, typically occurring within sequential seizure patterns rather than isolation. The electrographic-only phenomenon represents the majority of neonatal seizures occurring when EEG changes lack clinical manifestations. This critical recognition fundamentally changed neonatal seizure management, emphasizing that clinical observation alone misses most seizure activity and that EEG monitoring remains essential for accurate diagnosis and treatment assessment. The smear mnemonic provides systematic differentiation between jitteriness and seizures, preventing diagnostic errors that lead to unnecessary anticonvulsant exposure or missed seizure treatment. Stimulus sensitivity offers immediate diagnostic clarity. Jitteriness exhibits exquisite sensitivity to gentle stimulation, environmental changes, or tactile input, while seizures remain unaffected by external stimuli and continue their pattern regardless of intervention attempts. Movement quality demonstrates distinct patterns. Jitteriness produces symmetric tremor with equal amplitude and rate in both flexion and extension phases. Seizures generate asymmetric clonic jerking characterized by rapid muscle contraction, followed by slower relaxation phases. Eye movements provide reliable differentiation. Jitteriness never involves abnormal ocular phenomena, maintaining normal gaze throughout episodes. Seizures frequently demonstrate eye deviation, fixation, or other abnormal eye movements accompanying motor activity. Autonomic changes distinguish seizure from benign movement. Jitteriness lacks associated autonomic phenomena, maintaining stable vital signs. Seizures may demonstrate tachycardia, blood pressure fluctuations, apnea, pupillary changes, or altered salivation patterns. Restraint response enables immediate bedside testing. Jitteriness typically stops with gentle passive flexion of affected limbs, allowing clinicians to halt episodes through simple positioning. Seizures persist despite restraint, continuing their pattern even when limbs are gently held. Smear enables confident clinical distinction, ensuring appropriate management decisions at the bedside. Phenobarbital remains the first-line therapy, achieving seizure control in approximately 50% of cases. The loading dose is 20 milligrams per kilogram administered intravenously over 10 to 15 minutes with careful respiratory monitoring. If seizures persist, additional doses of 10 to 20 milligrams per kilogram may be given, with a maximum total dose of 40 to 50 milligrams per kilogram. The target serum concentration is about 40 micrograms per milliliter. Doses above this range do not improve seizure control and only increase the risk of sedation and cardiovascular toxicity. Second-line options include levetiracetam, given as a loading dose of 50 milligrams per kilogram, followed by a maintenance regimen of 40 milligrams per kilogram per day. It has an excellent safety profile with minimal drug interactions. Phenytoin may also be used, with a loading dose of 20 milligrams per kilogram administered at a rate of no more than 1 milligram per kilogram per minute under continuous cardiac monitoring. When seizures are caused by metabolic disturbances, correction of the underlying abnormality must precede anticonvulsant therapy. For hypoglycemia, give 10% dextrose at 2 milliliters per kilogram intravenously, followed by a continuous infusion of up to 0.5 grams per kilogram per hour. For hypocalcemia, administer 10% calcium gluconate intravenously. Magnesium levels should also be checked, as hypomagnesemia often coexists. In many cases, correcting these metabolic disturbances resolves seizures without the need for anticonvulsant medication. The Volpe grading system classifies intraventricular hemorrhage by the proportion of ventricular volume involved. Grade 1 involves less than 10% of the ventricular volume, Grade 2 represents 10 to 50%, and Grade 3 involves greater than 50% of the volume with or without ventricular distension. Periventricular hemorrhagic infarction is recognized as a separate process, distinct from simple venous infarction and not merely an extension of intraventricular bleeding. Major risk factors include gestational age less than 32 weeks, fluctuations in cerebral blood flow, and complications such as pneumothorax. The majority of hemorrhages occur within the first 24 to 48 hours after birth, with the period of highest risk extending through the first 3 to 4 days of life. Several strategies reduce the likelihood of intraventricular hemorrhage. Delayed umbilical cord clamping helps stabilize blood volume, while synchronized ventilation prevents harmful intrathoracic pressure swings. Administration of antenatal corticosteroids promotes vascular maturation, lowering the risk of fragile vessel rupture. Gentle handling during the vulnerable early postnatal period further minimizes abrupt pressure changes that could trigger hemorrhage. Grade 1 and 2, some generally good prognosis, but 7% increased risk of poor outcomes compared to no IVH. Grade 3, 35% risk neurologic sequelae, 18% require shunt placement. Grade 4/PVL, 55% risk severe impairment, 29% require shunt. Highest mortality rates. PHVD develops 2 to 4 weeks after hemorrhage in 25 to 50% of severe cases. Clinical signs include rapid head growth, full fontanelle, sutural separation, though ultrasound changes precede symptoms by weeks. Earlier intervention shows improved outcomes. Monitor with serial head circumference and ultrasound using ventricular index measurements. Treatment timing balances intervention risks against progressive white matter injury from prolonged ventricular compression. PVL strikes between 23 to 32 weeks when pre-oligodendrocytes dominate the white matter. Unlike cell death, PVL causes a maturation arrest. These immature cells get stuck and can't develop into mature oligodendrocytes. The pathophysiology centers on this critical vulnerability window combined with hypoxia, ischemia, and inflammation, particularly from chorioamnionitis and postnatal sepsis. The classic PVL pattern creates spastic diplegia because descending motor fibers to the legs run closest to the lateral ventricles, making them most vulnerable to periventricular injury. Arms are relatively spared because their fibers course more laterally. When PVL extends into the centrum semiovale and corona radiata, you'll see upper extremity involvement plus visual and cognitive deficits. Cerebral autoregulation maintains constant blood flow despite blood pressure fluctuations, a critical protective mechanism that's underdeveloped in preterm infants. These babies exist in a pressure-passive state, where cerebral blood flow directly tracks blood pressure changes, leaving their brains vulnerable to both hypoperfusion and hyperperfusion. This immature autoregulation develops with gestational age, but even term infants lose this protection when hit with severe asphyxia, hypoxia, head trauma, or hypercapnic acidosis. In sick preterm infants, routine caregiving can trigger dangerous cerebral blood flow fluctuations. The clinical implication is profound. Blood pressure instability directly translates to brain injury risk, particularly intraventricular hemorrhage and white matter damage. Hydrocephalus classification hinges on CSF flow obstruction patterns. Communicating hydrocephalus results from impaired CSF reabsorption, typically post-hemorrhagic from blood products clogging arachnoid granulations, or post-meningitic from inflammatory debris. Non-communicating hydrocephalus involves structural blockages. Aqueductal stenosis narrows the aqueduct of Sylvius, Dandy-Walker malformation affects fourth ventricular outflow, and Chiari II malformation creates posterior fossa crowding. Clinical recognition relies on progressive signs, rapidly increasing head circumference crossing percentile lines, tense bulging fontanelle, sunsetting eyes from increased intracranial pressure, and separated sutures. Management centers on CSF diversion. VP shunts for most cases. Endoscopic third ventriculostomy for selected non-communicating types. Early intervention prevents irreversible brain compression and optimizes neurodevelopmental outcomes. Neural tube defect classification centers on tissue involvement and structural integrity. Open defects expose neural elements. Meningocele involves only herniated meninges through the vertebral defect, with the spinal cord maintaining normal position and function. Myelomeningocele includes neural elements in the herniation, creating neurologic deficits below the lesion level. Closed defects maintain skin coverage. Spina bifida occulta represents isolated vertebral arch failure without neural involvement. Lipomyelomeningocele combines a subcutaneous lipoma that extends intradurally to tether the spinal cord, often causing progressive neurologic deterioration. Emergency management demands immediate sterile dressing application, prone positioning to protect exposed neural tissue, and surgical closure within 24 to 48 hours to prevent infection and further cord damage. The urgency reflects infection risk. Meningitis can devastate these vulnerable infants. Chiari II malformation occurs almost universally with lumbar myelomeningocele due to CSF leakage in utero, causing hindbrain descent below the foramen magnum. Clinical signs include apnea, stridor, dysphagia, and weak cry from brainstem compression. Recognition is crucial. These symptoms can be life-threatening and may worsen with untreated hydrocephalus. Hydrocephalus develops in 80 to 90% of cases, particularly with lumbar lesions where the incidence reaches 90%. Post-surgical closure often unmasks hydrocephalus as CSF leakage stops and pressure increases. Functional level directly correlates with anatomical lesion level. Lumbar lesions affect ambulation, while thoracic lesions create more extensive paralysis. Prevention remains paramount. Maternal folate supplementation at 400 micrograms daily reduces neural tube defect risk by up to 70%. Craniosynostosis creates predictable head shapes based on which suture fuses. Sagittal synostosis produces scaphocephaly, the classic boat-shaped head with compensatory frontal bossing and occipital prominence. It's the most common pattern, affecting 1 in 1,000 births with 4 to 1 male predominance. Metopic fusion creates trigonocephaly, the triangular forehead with vertical keel and associated hypotelorism. Unilateral coronal synostosis causes anterior plagiocephaly with ipsilateral frontal flattening and contralateral bossing. Bilateral coronal fusion results in brachycephaly, the shortened anteroposterior dimension. The key clinical differentiator from positional plagiocephaly is the palpable ridge along fused sutures. Ear positioning is crucial. Synostosis moves the ear backward and posteriorly, while positional deformation shifts it forward. This simple examination finding prevents unnecessary imaging. Cerebral palsy presents as non-progressive motor and posture disorders from early brain lesions. Spastic CP accounts for 85% of cases, particularly diplegia and hemiplegia in preterm infants. Risk escalates dramatically with prematurity, 1 in 1,000 in term infants versus 100 in 1,000 in extremely preterm. Early recognition centers on persistence of primitive reflexes beyond 6 months, abnormal tone patterns, initial hypotonia often preceding spasticity, asymmetric movements, and feeding difficulties from poor suck-swallow coordination. The paradox: infants destined for spastic CP typically begin hypotonic with poor head control and back support, developing spasticity later. Definitive diagnosis requires waiting until 3 to 5 years when motor patterns fully establish. However, the general movement assessment offers the most sensitive early prediction tool for identifying high-risk infants requiring intervention services. aEEG provides amplitude-compressed, time-compressed EEG from 2 to 4 electrodes over central parietal regions, creating bedside interpretable tracings. Seizures appear as sudden sustained elevation of upper and lower margins with accompanying monomorphic raw EEG patterns. The major advantage is bedside availability without specialized EEG technologists. However, limitations are significant. Neonatologists detect only 12 to 38% of individual seizures identified on conventional EEG. aEEG misses brief seizures, low-amplitude seizures, and focal seizures outside electrode coverage. High susceptibility to artifacts from movement, ventilator oscillations, and ECMO further compromises accuracy. In preterm infants, aEEG shows concerning overdetection, 48% seizure incidence versus only 5% on conventional EEG in similar populations. Best practice: use aEEG as screening tool, confirm suspected seizures with conventional EEG. NIRS measures cerebral regional oxygen saturation, RSCO2, through near-infrared light absorption by oxygenated and deoxygenated hemoglobin in cortical tissue. This provides real-time, non-invasive monitoring of cerebral oxygenation and hemodynamics. In HIE, NIRS reveals a characteristic biphasic pattern. Cerebral oxygenation decreases during the first 4 to 6 hours, then slowly increases within 24 hours. The initial decrease is less pronounced in severely affected infants due to reduced metabolic activity. Critical finding: infants with persistently elevated cerebral oxygenation after 24 hours show more significant MRI injury and worse 2-year neurodevelopmental outcomes. Additional applications include monitoring autoregulation status in preterm infants, detecting pressure-passive cerebral circulation, assessing procedural effects on cerebral hemodynamics, and guiding blood pressure management decisions. Central hypotonia accounts for 60 to 80% of neonatal hypotonia. Key differentiator: central causes show hypotonia exceeding weakness with preserved anti-gravity power, while peripheral causes demonstrate weakness equal to or greater than hypotonia with absent or diminished reflexes. Red flags for neuromuscular disease include decreased fetal movements, polyhydramnios from poor fetal swallowing, tongue fasciculations, and respiratory distress from birth. Additional peripheral signs: absent deep tendon reflexes, arthrogryposis, and characteristic positioning abnormalities. Clinical approach centers on determining hypotonia distribution, axial versus appendicular, assessing strength generation despite hypotonia, and checking reflexes. Creatine phosphokinase elevation suggests muscle disease, but normal levels don't exclude it. Spinal muscular atrophy now has time-sensitive treatments, making early genetic testing critical. Always examine the mother for myotonic dystrophy signs, grip myotonia, or percussion myotonia. SMA represents a revolutionary transformation from universally fatal to treatable disease. 95% of cases involve homozygous SMN1 deletion, with SMN 2 copy number modifying severity. Classic presentation includes tongue fasciculations, proximal weakness exceeding distal, bell-shaped chest from intercostal muscle weakness with relative diaphragm sparing, and absent reflexes despite bright facial expression. Newborn screening now identifies pre-symptomatic cases, enabling early intervention when treatments are most effective. 3 FDA-approved therapies have transformed outcomes. Nusinersen, intrathecal antisense oligonucleotide, showed 51% of treated infants gained motor milestones versus 0% controls. Zolgensma, single-dose intravenous gene therapy, delivers SMN1 gene via AAV9 vector. Risdiplam, oral SMN2 splicing modifier, offers convenient administration. Critical timing: pre-symptomatic treatment yields dramatically better outcomes than symptomatic treatment. This time sensitivity drives urgent genetic confirmation and neurologic consultation for positive screens. Congenital myotonic dystrophy results from CTG repeat expansion greater than 1,000 in the DMPK gene, with rare exceptions showing maternal inheritance due to male oligospermia and preferential expansion during oogenesis. The characteristic tent-shaped mouth, inverted V upper lip, with facial diplegia and ptosis, creates a distinctive carp mouth appearance. Clinical presentation includes profound hypotonia requiring resuscitation, respiratory distress from muscle weakness, plus pulmonary immaturity, poor suck-swallow reflexes risking aspiration, and often clubfoot. Pregnancy history reveals polyhydramnios from fetal swallowing failure and decreased fetal movements. The diagnostic clue is maternal examination. Always test for grip myotonia by having mother squeeze hand tightly, then release quickly, or percussion myotonia at thenar eminence. Many mothers are undiagnosed with subtle features like frontal balding, ptosis, or temporal wasting. Prolonged mechanical ventilation greater than 30 days carries poor prognosis, though survivors typically achieve independent ambulation by age 3. Neurodevelopmental care principles recognize that NICU stress significantly impacts brain development in preterm infants. Environmental modifications provide neuroprotection during critical brain development periods. Light management involves establishing diurnal cycling to support circadian rhythm development, while reducing bright light exposure that can disrupt sleep and stress responses. Sound reduction maintains baseline levels less than 45 decibels, as excessive noise contributes to procedural stress and altered brain development patterns. Pain management proves essential for neuroprotection. Research demonstrates that procedural pain and NICU stress predict altered corticospinal tract development and cortical thickness changes. Untreated pain affects cognitive and behavioral outcomes at 18 months. Family integration through skin-to-skin care and cue-based feeding supports parent-infant bonding while reducing stress for both. Positioning maintains physiologic flexion and midline orientation, supporting normal motor development patterns. Clustered care respects sleep-wake cycles, allowing uninterrupted sleep periods critical for brain development. HIE prognostication relies on multimodal assessment, combining clinical examination, EEG background patterns, and MRI findings. EEG background proves most predictive. Normal patterns by 6 hours with continued normalization show 100% positive predictive value for normal outcomes at 2 years. Severe patterns like persistent burst suppression, extremely low voltage, less than 5 microvolts, or flat tracings after 48 hours predict poor outcomes. Return of sleep-wake cycling indicates favorable prognosis. EUFVH outcomes correlate directly with grade severity and development of ventriculomegaly. Grade 1 to 2 hemorrhages generally resolve without sequelae, while grade 3 to 4 associate with significantly increased disability rates, particularly when complicated by post-hemorrhagic hydrocephalus. Stroke prognosis depends on lesion size, location, and associated injuries. Watershed patterns typically yield better outcomes than deep gray matter involvement affecting thalamus and basal ganglia. The fundamental principle, underlying etiology, determines outcome more than seizures or symptoms themselves. Seizure burden and EEG background patterns provide independent prognostic value across all conditions. Family counseling requires careful timing and approach. Most accurate predictions emerge after the first week when acute physiologic instability resolves and diagnostic studies provide clearer pictures. However, transient neurologic findings may persist until 18 to 24 months, requiring ongoing reassessment. Present ranges rather than absolutes. Avoid definitive statements when uncertainty exists. Research shows that even children with similar injuries can have vastly different outcomes due to environmental factors, early intervention effectiveness, and individual resilience factors. Focus discussions on underlying etiology as the primary outcome determinant, not just symptoms. A child with HIE secondary to cord compression may have different prognosis than one with genetic syndrome plus HIE. Support families with early intervention connections and realistic hope. Studies demonstrate that prompt sharing of diagnostic results, immediate referral to services, and ongoing communication significantly reduce parental stress. Connect families with appropriate specialists and parent support networks. Emphasize that many adults born preterm report similar quality of life to term-born peers, providing balanced perspective on long-term outcomes. Subgaleal hemorrhage represents the most dangerous birth trauma emergency. The key triad, bleeding that crosses suture lines, history of vacuum delivery, especially difficult extraction, and progressive head enlargement over hours. Unlike caput succedaneum, which resolves, subgaleal hemorrhage continues expanding as blood accumulates in the potential space between skull periosteum and scalp aponeurosis. This can lead to exsanguination, as infants may lose 40% of blood volume into this space. Immediate volume resuscitation and urgent surgical consultation are essential. Severe hypoxic ischemic encephalopathy presents with the classic tetrad: comatose state, complete flaccidity, absent primitive reflexes, and frequent seizures, often progressing to status epilepticus. These findings distinguish severe from moderate hypoxic ischemic encephalopathy and predict poor outcomes even with therapeutic hypothermia. Increased intracranial pressure manifests with bulging fontanelle as the most sensitive early sign, bradycardia as a late ominous sign, indicating brainstem compression, apnea episodes, and sunsetting eyes showing forced downward gaze from tectal compression. This constellation requires emergent intervention. Status epilepticus, defined as continuous seizure activity greater than 30 minutes, carries significant morbidity risk. Always consider metabolic causes first, as hypoglycemia, hypocalcemia, hypomagnesemia account for many treatable seizures. Phenobarbital remains first-line antiepileptic therapy. Standard loading, 20 milligrams per kilogram intravenous over 10 to 15 minutes. Assess response after 15 to 20 minutes. If seizures persist, give additional 10 to 20 milligrams per kilogram doses, up to maximum 40 to 50 milligrams per kilogram total load. Maintenance dosing, 5 milligrams per kilogram per day divided twice daily. Monitor levels 1 to 2 hours post-load, target 15 to 25 milligrams per liter. Note that therapeutic hypothermia delays phenobarbital clearance by 99%, requiring dose adjustments. Therapeutic hypothermia protocol initiate within 6 hours of birth for moderate severe hypoxic ischemic encephalopathy. Target core temperature 33.5 plus or minus 0.5 degrees Celsius maintained for exactly 72 hours, then controlled rewarming at 0.5 degrees Celsius per hour to normothermia. Cooling reduces cellular metabolism 5 to 8% per degree, providing neuroprotection during secondary energy failure phase. Subgaleal hemorrhage volume resuscitation. These infants can rapidly develop hypovolemic shock. Use crystalloids for initial expansion, but prepare for blood products, packed red cells, fresh frozen plasma, platelets. Monitor hemoglobin closely as blood loss continues. Pyridoxine trial essential for refractory seizures, 100 milligrams intravenous over 5 minutes with continuous electroencephalogram monitoring. May cause transient apnea in responders due to gamma-aminobutyric acid surge. If no immediate response, additional 100 milligrams doses up to 500 milligrams total, or begin maintenance 100 milligrams per day while awaiting genetic confirmation. Favorable outcome. Predictors center on early recovery patterns. Normal electroencephalogram background by 6 hours of age with sustained normalization shows 100% positive predictive value for normal outcomes at 2 years. This reflects minimal brain injury and preserved neuronal function. Quick clinical recovery with normalization of tone, reflexes, and feeding within 24 to 48 hours strongly predicts good outcomes. Normal neurologic examination at discharge carries more weight than early abnormal findings, as acute hypoxic ischemic encephalopathy symptoms may not reflect permanent damage. Normal magnetic resonance imaging in the first week, particularly absence of basal ganglia, thalamic, or posterior limb internal capsule injury, correlates with favorable motor and cognitive development. Poor outcome predictors include persistently abnormal electroencephalogram background beyond 48 hours with burst suppression, extremely low voltage less than 5 microvolts, or flat tracings indicating severe neuronal injury. These patterns, especially when unchanged after 72 hours, predict death or severe disability. Magnetic resonance imaging findings, predicting poor outcomes. Basal ganglia and thalamic injury, particularly when bilateral, strongly predicts both motor and cognitive impairment. Posterior limb internal capsule injury on diffusion-weighted imaging predicts cerebral palsy. Watershed injury typically yields better outcomes than deep gray matter involvement. Refractory seizures requiring multiple antiepileptics indicate severe brain injury. Multiple system involvement with renal failure, liver dysfunction, cardiac complications suggests global hypoxic ischemic insult with poor prognosis. New seizure-like activity requires systematic approach. First, immediately check glucose, calcium, and magnesium as metabolic causes are readily treatable, and seizures may resolve with correction. Hypoglycemia, less than 40 milligrams per deciliter in term infants, can cause permanent brain damage if untreated. Differentiate true seizures from jitteriness using 5 key features. Jitteriness stops with gentle restraint, is stimulus sensitive, lacks abnormal eye movements, shows normal mental status between episodes, and demonstrates amplitude decrease with passive flexion. True seizures persist despite restraint, occur spontaneously, feature abnormal eye movements like deviation, jerking, or staring, alter consciousness, and maintain amplitude with passive movements. Obtain electroencephalogram confirmation when possible, as clinical signs correlate poorly with electrographic seizures. Many true seizures are subclinical, detected only by electroencephalogram monitoring. If seizures confirmed and metabolic causes excluded, load with phenobarbital 20 milligrams per kilogram intravenous. Head trauma evaluation follows anatomic principles. Swelling that crosses suture lines indicates caput succedaneum, which is benign and resolves spontaneously, or subgaleal hemorrhage, which is an emergency if progressive. Subgaleal requires immediate recognition, as progressive enlargement over hours distinguishes it from caput. Swelling confined by sutures indicates cephalohematoma with blood between skull and periosteum. Usually benign, but monitor for underlying skull fracture. Never attempt aspiration, as this risks infection. Here are the most commonly tested topics I've found. Birth trauma, differentiation critically important, as subgaleal hemorrhage recognition can be life-saving. Remember the triad: crosses sutures, vacuum delivery history, progressive enlargement. This distinguishes it from benign caput succedaneum. Hypoxic ischemic encephalopathy, Sarnat staging, and therapeutic hypothermia criteria frequently tested. Moderate severe hypoxic ischemic encephalopathy, stages 2 to 3 within 6 hours of birth, qualifies for cooling. Sarnat stage 1, mild hypoxic ischemic encephalopathy remains controversial for cooling eligibility. Differentiation between seizures and jitteriness appears on every examination. Master the 5 distinguishing features: restraint response, stimulus sensitivity, eye movements, mental status, and amplitude changes with passive movement. Intraventricular hemorrhage, grading and outcomes. Grades 1 to 2 generally benign. Grades 3 to 4 carry significant morbidity risk. Grade 4 actually represents periventricular hemorrhagic infarction, not true intraventricular extension. Post-hemorrhagic hydrocephalus significantly worsens prognosis. Neural tube defect management emphasizes surgical timing with closure within 48 hours to minimize infection risk and optimize outcomes. Multidisciplinary approach, essential, involving neurosurgery, urology, orthopedics. Key principles guide all neonatal neurology care. Systematic assessment prevents missed diagnoses. Early intervention during critical periods maximizes neuroprotection. Honest but hopeful family counseling builds trust and realistic expectations, and multidisciplinary coordination ensures comprehensive care for complex conditions. A term infant delivered by vacuum extraction develops a fluctuant swelling over the scalp that crosses suture lines and extends from the orbital ridge to the nape of the neck. The infant becomes pale and irritable with decreasing hematocrit. This condition is best described as caput succedaneum, cephalohematoma, subgaleal hemorrhage. This question is testing your understanding of birth-related head injuries and their clinical presentations. Subgaleal hemorrhage is correct because it presents as bleeding into the potential space between the galea aponeurotica and periosteum, allowing blood to track across suture lines and extend widely from the orbital ridge to the neck. The decreasing hematocrit and changes in clinical status reflect significant blood loss into this large potential space, which can accommodate up to 260 milliliters of blood, over 50% of a neonate's blood volume. Caput succedaneum is incorrect because while it crosses suture lines, it resolves within 24 to 48 hours and doesn't cause hemodynamic compromise. Cephalohematoma is incorrect because it is confined by periosteal attachments and cannot cross suture lines. A term infant born via emergency cesarean section for fetal bradycardia has APGAR scores of 3, 5, and 6 at 1, 5, and 6, 10 minutes respectively. Cord blood gas reveals pH 6.9 and base deficit minus 18 milliequivalents per liter. At 4 hours of life, the infant is lethargic with hypotonia, weak reflexes, and intermittent bradycardia. Which therapeutic intervention is indicated? Immediate EEG monitoring only. Phenobarbital loading dose. Therapeutic hypothermia. This question is testing your knowledge of hypoxic ischemic encephalopathy diagnosis criteria and management. Therapeutic hypothermia is correct because this infant meets all criteria for cooling. Term gestation, less than 6 hours of age, evidence of perinatal asphyxia, low APGAR scores and significant acidosis on cord gases, and clinical evidence of moderate encephalopathy, Sarnat stage 2, based on lethargy, hypotonia, weak reflexes, and intermittent bradycardia. Immediate EEG monitoring only is incorrect because while monitoring is important, it delays the time-sensitive neuroprotective intervention needed. Phenobarbital loading dose is incorrect because although seizures may develop in HIE, this infant is not currently having seizures, and prophylactic anticonvulsants are not indicated as first-line therapy. A preterm infant born at 28 weeks gestation has a routine cranial ultrasound on day 3 of life showing blood filling approximately 60% of the lateral ventricles with ventricular dilation. According to the Papaly classification, this represents Grade 1 hemorrhage, Grade 2 hemorrhage, Grade 3 hemorrhage. This question is testing your ability to classify intraventricular hemorrhage using the Papaly/Volpe grading system. Grade 3 hemorrhage is correct because it is defined as IVH with blood filling more than 50% of the ventricular volume with ventricular dilation. Grade 1 hemorrhage is incorrect because it involves bleeding confined to the subependymal germinal matrix only without ventricular blood. Grade 2 hemorrhage is incorrect because while it involves intraventricular blood, it fills less than 50% of the ventricle and occurs without ventricular dilation. A term infant is born with a skin-covered sac protruding from the lumbosacral area. Neurological examination shows normal lower extremity movement and reflexes. The most appropriate initial management includes immediate surgical repair, sterile moist dressing, and prone positioning. Watchful waiting for 1 to 2 weeks. This question is testing your knowledge of neural tube defects and their initial management. Sterile moist dressing and prone positioning is correct because it provides appropriate initial care for a neural tube defect, likely meningocele, while preventing infection, trauma to the sac, and allowing for proper planning of definitive repair. Immediate surgical repair is incorrect because while surgical closure is needed, it requires proper preoperative evaluation and planning, though it should typically occur within 24 to 72 hours of birth. Watchful waiting for 1 to 2 weeks is incorrect because it increases risk of infection, sac rupture, and CSF leakage. Timely repair is necessary to prevent these complications. A term infant develops rhythmic jerking movements of the right arm 18 hours after birth following perinatal asphyxia. The movements cannot be suppressed with gentle restraint. This seizure type is best classified as focal clonic seizure, myoclonic seizure, subtle seizure. This question is testing your ability to recognize and classify neonatal seizure types. Focal clonic seizure is correct because it presents as rhythmic jerking, clonic movements limited to one area of the body, right arm, that cannot be suppressed by restraint. The timing, 18 hours after birth, following perinatal asphyxia, is also classic for HYE-related seizures. Myoclonic seizure is incorrect because myoclonic seizures are characterized by rapid, lightning-fast jerks without the rhythmic quality of clonic movements. Subtle seizure is incorrect because subtle seizures typically present with less obvious manifestations, such as eye deviation, oral buccal movements, or bicycling motions, rather than rhythmic limb movements.